hope you guys have been having a nice day. Today is another webinar, and we'll be talking about stroke evaluation and management. We know how important it is to talk about stroke because we know in our daily practice we've had to manage stroke at some point. So we'll be talking a lot extensively about stroke. And I'm Dr. Mariam Inuwa.
And Dr. Temitope Oyetunji.
So we'll be going through those objectives. Okay, sorry.
Okay, so at the end of this webinar, we expect that every participant should be able to understand the different stroke subtypes and their pathophysiology. We expect us to be able to understand the basic principles of stroke evaluation and management, to appreciate the common pitfalls in stroke management, and then to learn about the principles of primary and secondary stroke prevention. Okay, so we're going to be going through this outline. We'll give an introduction, and then we'll talk about the epidemiology of stroke. We'll talk a little bit about anatomy, focusing on the blood supply to the brain. And then we'll talk about the pathophysiology of the different stroke subtypes, the evaluation, including the history, examination, investigations, and then we go to treatment, complications, and we'll give a summary. Okay, so we're just going to present this case just to whet our appetite, and we're going to expect that we're going to answer the question. So the first case is a 40-year-old woman who was transferred to our facility with a 3-hour history of sudden loss of consciousness, which ensued while engaged in a heated argument. She had been hypertensive for 8 years with poor medication adherence, and prior to transfer, she was given 250 ml of IV 20% mannitol and IV labetalol 25 milligrams stat. She arrived still deeply unconscious with GCS of 3. She had normal sized but poorly reactive pupils. Her pulse was 88 beats per minute. BP was 206 over 80 millimeter of mercury. She had an MAP of 122. So the question is, the mean arterial pressure is appropriate to maintain cerebral perfusion. That mean arterial pressure, which was 122, is it appropriate to maintain cerebral perfusion? Then is this a case of hemorrhagic stroke? Then the third option, she should be managed in the general ward. Then D, she should be given aspirin. And then the final one, we can maintain the present blood pressure for 24 hours. So which is the correct answer? We can leave our answers in the Q&A box.
I'm sorry, just to draw attention to the brain CT. This is the brain CT of the case that was discussed. So please, we can put in our answers. And then at the end of the presentation, the whole idea is we'll then know the answer to this case. We just want us to think about it, understand the reasons behind why we do what we do in the management of stroke. So please, you can put in your answers. We'll just give you some few seconds to do that. Either A, B, C, D, E. You can put it in the chat box or the Q&A, whichever one that's convenient. And then we'll go through it at the end of the presentation. Then at the end of the presentation, we will definitely know what the answer is. So please, moving on, what is stroke? And we know that stroke is an abrupt onset neurological deficit. It's lasting more than 24 hours and is of a vascular origin, or an imaging showing that there is an infarction or an hemorrhage. Either we're doing it on autopsy, if we lose the patient less than 24 hours, or we get to do the brain CT even beyond 24 hours and we are seeing signs of infarction and hemorrhage, then we know we are dealing with a stroke. But why is it different from a transient ischemic attack? Because they could also present with the same focal neurological deficits, vascular origin, but is less than 24 hours, and imaging does not confirm any infarction. So even when you do a brain CT with no imaging evidence of an infarction, but they'll present with sudden onset weakness or slurred speech, and they'll tell you it just happened for some few minutes, or within 24 hours, they just recovered full power and were able to go about their regular activities. These same people are very important because they can come down with the full stroke, and we need to avoid that from happening. So acute, when we talk about stroke, majorly we have two types. Acute, we have the ischemic stroke and the hemorrhagic stroke. So acute ischemic stroke is characterized by the sudden loss of blood supply to that region of the brain. You know, it's a vascular thing. So once there's any, there's blood, when there's cut off of blood supply to that part of the brain, then we know that it's ischemic. So we're talking about once it's ischemic, it could either be thrombotic or embolic. There's either a thrombus there that has cut off the blood supply, or if it's hemorrhagic, there's a bleed affecting the particular part of the brain. So this diagram is just telling us that we have more of ischemic strokes presenting. So 80% of the strokes we get to see are ischemic. And then we have the 20% that's hemorrhagic. And under ischemic, there are two types. It could either be thrombotic or embolic. And of course, thrombotic, we see thrombotic more. Embolic could be more of a, maybe the person is having a cardiac issue and then presenting with a cardiac embolic stroke. Then for hemorrhagic, is either there's a bleed, and it could either be intracerebral or subarachnoid. All of this is so important because the mode of treatment is totally different. So it's important we are able to tell what kind of stroke we're dealing with so that we know how to approach and manage properly.
So talking about the epidemiology of stroke, now the global stage, stroke remains the second leading cause of death, and then is the third leading cause of death and disability combined. And in the US, nearly 800,000 people suffer from strokes every year. And of these 800,000, 82 to 92% of these strokes are ischemic. So most of the strokes are actually ischemic. And then according to the WHO, 15 million people suffer stroke worldwide each year. And of these people, 5 million die, and another 5 million are left permanently disabled. This is just to tell us the burden, the big burden that stroke represents, and the reason why we should know about it and manage appropriately to reduce the mortality and morbidity associated with stroke. Okay, so in Nigeria, the current prevalence of stroke is 1.14 per 1,000, while the 30-day case fatality rate is as high as 40%. And then hospital-based studies in Nigeria has shown that stroke is still the leading reason for neurological admission. So of all patients that are admitted into hospitals for neurological conditions, stroke is actually at the top of conditions that cause patients to need admission. So now I'll talk briefly about the anatomy. I'm not going to go into details and bore us because I know so many people don't like neuroanatomy. I did it when I was in school. I don't know about that anymore. But so I'll just talk about the major arteries that supply the brain. And I'll tell us the reason why we're talking about this. So we have three major arteries: the anterior, the middle, and the posterior cerebral arteries. And then in this table, we can see the structures that they supply. For example, the anterior cerebral artery supplies the medial, frontal, and parietal lobe. The middle cerebral artery supplies the lateral, frontal, and parietal lobes and other structures. And then we have the posterior cerebral artery supplying the occipital lobes, the medial and posterior temporal and parietal lobes. So these arteries supply these structures. And if we look at this diagram, it just depicts the blood supply of the brain. I'm sure everyone remembers what circle of Willis is. Yes, that one stands out. So I'm sure we remember what that is. And the arteries that majorly contribute to this include the anterior cerebral arteries and the anterior communicating artery, the posterior cerebral artery and posterior communicating artery, and the internal carotid artery. So now the reason, the clinical significance of knowing about this blood supply is that when any of these arteries are affected, there are particular sets of syndromes or signs that you see in the patient that makes you to know that, okay, maybe this is the anterior cerebral artery that was involved in this stroke. Which brings us to this table. Now, in this table, we can see that when the anterior cerebral artery is affected, you have contralateral hemiparesis, which is more severe in the lower limb. So if someone presents with paresis of the lower limb, which is more severe in the lower limb, you're thinking that might be from obstruction of the anterior cerebral artery. So they can also have other things. They can have urinary incontinence, they can have mental manifestations. And then for the middle cerebral artery, which is the most commonly affected artery in stroke, you can have speech defects. What is very notable about middle cerebral artery is that they have speech defects. They can have dysarthria, aphasia. Then you have contralateral hemiplegia and or hemiparesis involving the face, the arm, and the leg. And then you can also have homonymous hemianopsia as well. So for the posterior cerebral artery, we have also so many other symptoms that point to the posterior cerebral artery being the one affected by the obstruction. So, and then this table also goes ahead to show us the spectrum of symptoms or signs you can see for these other arteries.
So to add to what she talks about, it's important we know those things to expect, because when we're taking our history, those are the things we would ask, and that will point our attention towards where in particular is affected. And then it helps us to even pin down that diagnosis of stroke. Because if you don't ask these questions, they would not tell, you know, and then we would miss out the stroke and start following something else, because somebody else could come with irrational behavior and you're wondering, why is this person having irrational behavior? Could it be sepsis? Could it, you know, having a acute confusional state and all of that, not knowing that you've not asked other questions to pin down whether we're dealing with a stroke or not. So that's the whole idea of knowing the blood supply, the aspect where it supplies and what it controls, so that we can ask those questions during the history taking. So knowing what stroke is all about, the pathophysiology is very important, because that guides our management. That makes us understand why when we need to bring down the blood pressure, when we shouldn't, when we should hold on for a while, when we should have permissive hypertension. So going through ischemic stroke, you know, we talked about that when you're thinking of stroke, what's running through your mind is there a bleed or is there an infarction? So if you're dealing with ischemic stroke, if it is ischemic stroke, is it thrombotic? Is it a thrombotic event, or is it an embolic event that has caused the impaired blood flow to the area of the brain? So if it's a thrombotic event, we know that the blood flow to the brain is obstructed within a blood vessel due to a clot. And the clot could come up, it could be from a secondary arteriosclerotic disease or arterial dissection, or if it's an embolic event, that means most likely there is a cardiac pathology, or there's a clot formed somewhere, and then from the left side of the heart, it has gone through the internal carotid up to either the anterior cerebral artery or the middle cerebral artery. So normally in the brain, there's something we call cerebral autoregulation, which denotes the ability to maintain relatively stable cerebral blood flow, despite moderate shifts in perfusion pressure. So there's that autoregulation that is within a particular range, so that it can control the brain's activity and all. So no matter what the blood pressure is at a particular period, as long as it's within that range, there's good blood flow to the brain. And you know, once there's good blood flow to the brain, there's good oxygenation, and that we don't have any issues. Beyond this range, and that range we're talking about a mean arterial pressure of 60 to 150. Beyond this range, the brain's ability to compensate for perfusion pressure diminishes. So once you are dealing with very elevated blood pressure and you're knocking off that autoregulation, that means the blood supply to that brain reduces. This response poses a risk of ischemia at low pressures and edema at high pressures. So cerebral autoregulation becomes impaired once there's elevated blood pressure, which reduces blood flow and reduces perfusion and can cause neurological deficits. However, if the decrease in perfusion pressure exceeds the brain compensatory capacity, so that's what we've talked about, there's a particular range once that compensatory capacity is exceeded due to high blood pressure, because the blood pressure gradually starts increasing, the brain can maintain perfusion, but when it gets to a particular point, it can't tolerate it anymore, then there's a reduced blood flow to that segment of the brain. So in hypertensive individuals, autoregulation adapts to operate at a higher arterial pressure. Lowering blood pressure to normal levels at this stage would worsen the stroke. That's why it's important we understand the reason behind it, because the brain is now used to that high pressure. So initially, what you're trying to do when you're trying to control the blood pressure is not to bring it down, because that high flow is what the brain needs for perfusion at that stage. Then there's the issue of the penumbra region, which we're talking about, because once there's an infarction, the surrounding area, we try to see how we can preserve that due to collaterals and all of that. So there's something called ischemic penumbra. So this is an area around the core of ischemic tissue. So once there's a stroke or an infarction in a particular section of the brain, you're trying to see how we can preserve other aspects that are also ischemic and at risk of infarction. So that's why we said the whole idea of leaving the blood pressure for an ischemic stroke at that time is to ensure that there's still good perfusion to preserve those areas that are still at risk of an infarction. Precipitous drops in blood pressure can reduce blood flow to collaterals, resulting in hypoperfusion of that penumbra and leading to further neurological damage. So that is why at times you see cases where somebody comes in with elevated blood pressure, hemiparesis, and you're so worried about the blood pressure. Oh, bring down the blood pressure. Everybody's just blood pressure, you crash it. The power that was like 3/5 is now 0. It would worsen the neurological deficit. But the person that was still maybe altered sensorium is now really deeply unconscious, So that's why it's important to understand that the brain is now operating at a very high pressure, and we want to see how we can maintain it to preserve those areas that are that's at risk of infarction. For hemorrhagic, there's a bleed that occurs in the brain parenchyma. Usually the mechanism is through a leakage of some of the intracerebral arteries. So once there's high pressure and there's damage to the arteries in the brain, there's a leak there. Other mechanisms could be from if the patient is on anticoagulants or taking or on cocaine abuse and or the person has a bleeding diathesis. But the whole idea is that there's a bleed in the brain. And when we talk of subarachnoid hemorrhage, which is also part of, we talked about when there's a bleed, it's either it's intracerebral or subarachnoid. In subarachnoid, there's a bleed in the subarachnoid area. And this results from elevated intracranial pressure, which impairs cerebral autoregulation, and they come in with elevated blood pressure. This effect can occur in combination with other things like acute vasoconstriction, the microvascular platelet aggregation, loss of microvascular perfusion, and all of that reduces blood flow to that region. So this is a schematic diagram just trying to show us what happens when we talk of what was said in pathophysiology. You're either dealing with an ischemic stroke or hemorrhagic. Ischemic, there's blockage, clots, blocking blood flow to a particular section of the brain, and it's obstructing blood flow. While that's of hemorrhagic, there's a bleed. And for hemorrhagic, it's either it's intracerebral or it's subarachnoid.
Okay, so what are the risk factors for stroke? So we have 2 groups of risk factors. We have the non-modifiable risk factors and then the modifiable risk factors. So for the non-modifiable risk factors, at least there's nothing you want to do about these ones. We have age. So the older you are, the higher the risk of having a stroke. And then race is also important. We know that hypertension is common in the Black race. So and we know that hypertension is a major risk factor for stroke. So stroke is also common among Black people. And then sex, we know that stroke is commoner in males. And then ethnicity, the same with race. And then people that have migraine headaches with aura are also at risk of developing stroke. So we have people with fibromuscular dysplasia also being at an increased risk of developing stroke. And then people with family history of stroke also, or a transient ischemic attack. Once anybody has had a transient ischemic attack, that puts them at risk of developing a stroke in future. Then for the modifiable risk factors, just like I talked about, hypertension is the most important. And that is why we must do everything we can to make sure that patients with hypertension, make sure that the blood pressure is well controlled so that they don't develop stroke. So another modifiable risk factor is diabetes. And then we have cardiac conditions like atrial fibrillation, which is a very common cause of embolic stroke. And that is why we put this category of patients on anticoagulation just to reduce the risk of stroke. And then you also have valvular diseases, also heart failure, atrial and ventricular enlargement. All these cardiac conditions actually put a patient at risk. So when we see this in any patient that presents, they should already be, we should already be thinking about their risk of a stroke. So hypercholesterolemia also is an important risk factor, especially when it comes to thrombotic stroke. And then we also have transient ischemic attacks, like we have said, carotid stenosis, then lifestyle practices like excessive alcohol intake, tobacco use, illicit drug use. We just learned now that cocaine abuse is one of the causes of hemorrhagic stroke. So all these things can be risk factors, as well as physical inactivity to modifiable risk factors for stroke, obesity, oral contraceptive use, as well as sickle cell disease, which is also common in this environment. So now, how do we evaluate a patient for stroke? We go through the usual process. We take a history, we'll perform a physical examination, we carry out investigations, and then we manage the patient based on the results. So in the history, what are we looking out for? When a patient presents with loss of consciousness, of course, one of the differentials that must be running through your mind should be a stroke, because it's a common way that strokes can present, especially for hemorrhagic stroke. Then you have seizures also, especially when you have adult onset seizures. Maybe the person does not have a history of seizure disorder, and then they have other risk factors, and then they just suddenly developed seizures and then maybe lost consciousness. You should have stroke at the back of your mind as one of the differentials. And then hemiparesis, that's weakness, one-sided weakness when a patient presents with that. Vomiting, headache. Headache is a very common presentation of hemorrhagic stroke. We know that for subarachnoid hemorrhage, patients usually present with the worst headache of their life. So that's usually what draws attention to that. In ischemic strokes too, you can have headache, especially it can come as a prodrome to the stroke episode. Then slurred speech also, they can come with slurred speech, they can come with mild deviation, ataxia, aphasia, blurred vision, neck stiffness, and dysphagia, just problems swallowing. I think that was the way a patient presented once, just difficulty swallowing. That was the presentation, and lo and behold, it was a stroke. So these are some of the things that we'll see in the history that will make us begin to think about stroke, especially when that patient has risk factors that we can identify. And this mnemonic, be fast, I'm sure we have all heard of it before, is a very important mnemonic that we can use to recognize stroke. So this is supposed to be used both in the community and even in the hospital to recognize stroke. So the B is for balance. Is there balance loss or leg weakness? The E is for eyes. Are there any visual deficits? Then is there any facial weakness or arm weakness? Is there any speech loss or slurring? And then the T is for time, meaning that whenever you see any one of these signs, time is of the essence. You have to do something quickly because the outcome of that patient will depend on what you do. And then examining these patients on general examination, if you find absent ulcers, it can be a pointer to atherosclerosis, which is a risk factor for stroke. And then neurological examination is very, very important. We have to carry out a detailed, comprehensive neurological examination of this patient, starting with the consciousness level, the GCS, which can be depressed in hemorrhagic stroke. Like the patient represented, the case came with GCS of 3. Yes, so and she had hemorrhagic stroke. So consciousness level, then the cranial nerves, the examination of the cranial nerves, motor reflexes, cerebral function, gait, mental status. All of these are important because, as we have said, when you examine and you find some of these things, it may point you to the part of the brain that is actually affected or the artery that is affected. Then on cardiovascular examination, we can find irregular pulse. For example, if we find irregular pulse, that can point to atrial fibrillation, which is also a risk factor for stroke. Then elevated BP also can, confirm your suspicion. You're already suspecting that this might be a stroke, and then you do the BP and the BP is high. So that gives you an inkling that this might be a stroke. And if you hear murmurs also on cardiovascular examination, that could point to valvular heart diseases, which could also be a risk factor for stroke. So a thorough examination is actually very important, and not just limited to these systems, but a thorough physical examination is very, very important to not only diagnose stroke, but also exclude other things that the patient could present with. So what are the investigations that we must carry out? Brain imaging is at the top of that list. A brain CT is very, very important, and that is a non-contrast CT. It's very important. When a patient presents, if the patient is stable, as soon as they are stable, the first thing you want to do is to get a brain CT. And the very important thing that a brain CT does is that it excludes hemorrhage, because it's very sensitive in picking hemorrhage. So if you do your brain CT, no matter how early you do, if you do it very early, sometimes you might not be able to pick features of ischemia, even if they are there, but at least you'll be able to rule out hemorrhage, which will guide your management. So a brain CT is very important. As soon as possible, you need to get a brain CT. Then MRI also can be done. Why brain CT is preferred is that it's easily accessible, the cost is lower, and like we have said, it is sensitive to pick hemorrhage. But MRI is actually sensitive in picking ischemia, even in the very early stages. So MRI too can be used in to diagnose stroke. So apart from the brain imaging, other tests that we should do in this patient, very importantly, the HAL-BS. Need to do the HAL-BS to rule out things like hypoglycemia, which could actually also mimic stroke. Then also to rule out hyperglycemia as well, which can also present, it can be a comorbid condition that the patient is presenting with. Then a full blood count is also important. You might find polycythemia, for example, that may be the risk factor for that stroke. And then you could find infective features in cases like maybe endocarditis. That one can present with signs of infection. And then EUCR also is important. Lipid profile, like we have said, hypercholesterolemia is a risk factor. Then clotting profile is also important, especially in cases of hemorrhagic stroke. And then toxicology screening as well. Like we said, cocaine abuse can cause hemorrhagic stroke. So we also may need to do a toxicology screening, especially if you are suspecting that.
And then just to add to the lipid profile, the whole idea of the lipid profile too is not that would determine whether you're going to start statins or not, because they could have normal lipid profile, but at least if they have elevated cholesterol, either the LDL or the total cholesterol, we know that, yes, you really need to bring down that cholesterol level. But even if it is normal, we still would have to place this person on cholesterol medications. We'll talk about that in treatment. So your lipid profile, yes, it could be normal, but then we still need to place this patient on statins. So you could have a normal value, and you could also have an elevated value.
Okay. All right, so other investigations, we also need an ECG. ECG is very important because we can find arrhythmias on ECG. We have said atrial fibrillation could be a risk factor. So ECG is important. Then you may also need to do a Holter ECG, especially if you find an abnormal ECG. And then echo also can detect intracardiac clots. And also carotid Doppler ultrasound is also very important. It could also show maybe some plaques in the carotid, and that could have been the source of the embolus to the brain. So all these tests are very important, and they should be done as soon as the patient presents.
So for anybody presenting with stroke, regardless of whether they have murmurs or whether you're thinking it's cardioembolic or not, we must always do that Holter for them, because that could just be the key. Because the ECG, you know, when we do ECG, just for some few seconds,
yes.
But for the Holter, it runs for either 24 hours or 48 hours. And that's when you might even pick an arrhythmia, maybe a paroxysmal atrial fibrillation with the Holter, which could lead to the answer that, oh, this person has a cardioembolic stroke, especially when they come with repeat strokes and all that. So it's key that everybody that has had a stroke must have Holter done. You must have your carotid artery scanned, you know. So it's really, really important. Okay. And then, of course, an echo.
All right. Okay, so this is a CT image. So when we do CT, what are we looking for? Yeah, so this image is showing, if you look at it very well, on the left side, some portions are darker than the rest. So we call that hypodensity. So that's how you recognize ischemia on CT. So you just see that it's darker. Just know it's darker. That's one way to remember it. It's darker than the rest of the brain parenchyma. We can see it. So we can see this on the left. There is ischemia. So this is an ischemic. This is a CT showing an ischemic stroke. And then for this, we can see the difference. Now this one is whiter. We call them hyperdensities. So that's how you recognize hemorrhage on CT. So hemorrhage is white, ischemia is dark. That's just a layman or even a way of remembering it. Yeah, so hypodensity and hyperdensity. So when you pick a CT, even if your radiologist is not around, at least you can have an idea of what you're dealing with.
Because we are cautious of time. Remember the B fast, the T part of it. So we're not waiting for radiographers to report. Once the CT has been done, pending when the radiographers come to tell us all the details of, oh, it's affecting this segment of the brain, is this blood supply, blah, blah, blah. At least to start off with, there's a bleed or there's an infarct. We should be able to make that diagnosis immediately so that whatever we have to do, we can do it on time, because time is going, and the earlier we intervene, the better. So going through the treatment, we've talked about how we should understand the emergency in stroke, because stroke is a medical emergency. We need to be able to make that diagnosis on time. Once a patient comes in, we might not be able to take the full history immediately because it's an emergency. We need to be able to act immediately, take important history to help us pin our diagnosis, and then immediately let the person go for a brain CT. Within some minutes, that's within 30 minutes, 45 minutes, you should have a brain CT available so that we can make a decisive decision on what path to go. Are we dealing with hemorrhagic or we're dealing with ischemic? While all that is going on, remember that these patients can come in unconscious. So you need to take care of the person as a whole. You know our usual airway, breathing, circulation pattern. So we need to understand if this patient is unconscious, you know, first of all, we already know medical emergency, stroke, low GCS, you're already thinking of your intensive care units. Hemorrhagic stroke, we're already thinking of intensive care units where this patient will be monitored closely and properly. So once a patient comes in, is the airway patent? Is there anything we need to do about the airway? Is there need for intratracheal tube? You know, sometimes they might not come in unconscious. It might just be hemiparesis and slurred speech. But for those that are unconscious, let's ensure that the airway, we are able to offer them whatever they need for the airway to be patent. Either we put in an intratracheal tube if the GCS is low. Breathing, do they need oxygen or not? Is the saturation good enough? Our target is 94%. So remember that this patient can come with other comorbidities. So the stroke could be existing with other things going on. The person could also present with heart failure. The person could present with pulmonary edema. The person could present with elevated with hyperglycemic crisis. It could be sepsis also alongside with the stroke, you know. So we're trying to address everything as a whole as we're trying to prepare the person to go for the brain CT so that we can know precisely what's going on. Circulation, as the person comes in already, we know we are setting the line. We're ensuring that to start with, normal saline is going on, regardless of blood pressure. But of course, if you're dealing with somebody that comes in with symptoms of autopnea, PND, you know, their crepitations in the chest, elevated GAVP, markedly elevated blood pressure, you know that the stroke you're dealing with is not just only stroke. There's a component of the heart there. This person could be in heart failure too. So you're mindful of your fluid so that you can strike a balance as you want to help improve perfusion in the brain. You also don't want to worsen and cause more pulmonary edema. So you have to strike a balance there. So with the fluids, as much as we want to give fluids, but it to be guarded, you don't want to give too much like you would normally want to do for a stroke patient when you don't want to give a minimum of 3 liters a day. Then we talk about our DVT prophylactics because sometimes, as we said, they're unconscious, they cannot move, hemiparesis or hemiplegia, they can't totally move the limb and all that, they're in bed for a while, and you don't want to worsen situations because if they come down with DVT, they would have PE, they will worsen all that will be managed. So at the end of the day, it's not just stroke alone you're dealing with, you're not dealing with PE that could have been prevented. So we want to prevent all of that from happening. Then, of course, we always do the swallow test for them. If they're conscious, we ask them to take little water. Let's see if they can, if they don't cough, you know, if they're able to swallow easily, there's no problem before you can start telling them to feed. Sometimes it's just the dysphagia, as she said. We had a patient like that. That was the only presentation, dysphagia. And of course, immediately we requested for a brain CT, and then there was a stroke. But dysphagia was a major thing the person came with. It was later on, by the time we started probing further, you know, the person started telling us about there was some slurred speech, but kind of like recovered fully, you know, but there was dysphagia that persisted. And despite all the places he went to, he still had the dysphagia still there, and then came to us. And before we made the diagnosis of the stroke, and then, you know, we then knew what next to do. So once they're unconscious, like you then pass an NG tube. The NG tube is for medications, NG tube is for feeding, you know. So, and then of course, we're nursing as an unconscious patient if the patient is brought in unconscious, where you know you're going to do your 30 degrees or 45 degrees head up, depending on if the person is so dyspneic. You know the 2-hourly toning we do for them when they're unconscious. You know, you want to prevent bed sores, and you want to pass your catheter to ensure strict input-output charts, ensuring that if they're not making enough urine, because they can also come in with renal impairments. Sometimes there could be uremia too going on too. So all of that we are monitoring based on our investigation results. And then if there's cerebral edema, for cerebral edema, at times it could just be the presentation, the history that will point towards, oh, the signs of increase in intracranial pressure. When you're getting a wide pulse pressure or bradycardia, you know, this person is having frequent vomiting, seizures, you know, you already know that even before your brain CT comes out, markedly elevated blood pressure, you know there's cerebral edema going on. So you can start your mannitol. And the good thing about the mannitol is, apart from taking care of the cerebral edema, it also brings down the blood pressure. So while we are still buying time with giving medications and all that, that mannitol will still have an effect. Then of course we talk about seizure medications. The seizure medications is based on the fact that they come in with seizures, you know. Then we'll talk more about the antiplatelets later on, and then we'll talk of high dose statins. We're talking about atorvastatin in the range of 40 milligram or 80 milligram, or if it's rosuvastatin, we're talking of 20 or 40. You know, so this is regardless of whether the cholesterol level is normal or not. We are placing them on that because we know the benefit of statins. Statins' benefit is not just to reduce the cholesterol level. You know, it has antioxidant property. It helps with epithelial damage. You know, help to plate stabilization and all of that. So it's not just statins isn't just only for cholesterol. It has other benefits on the blood vessels, and so that's one of the reasons why. And then it's also needed for secondary prevention of stroke. So that's why we do all that. Then remember that, of course, we're talking about the patient as a whole. The person can come with other things. There's risk of pneumonitis because the person cannot swallow well, or because the person is unconscious with aspirate. You know, sometimes you even hear stories like the relatives are still feeding them because they are concerned about, my brother has not eaten, you know, my mother has, you know, we hear all these sort of things. The person is unconscious. They don't understand that the person is unconscious, or especially when it's maybe altered sensorium, you know, they will still think that the person can still tolerate something. Then it's later we'll probe further and be wondering, all this vomiting, see food particles and all that, we are still feeding, you know. So the person is at risk of pneumonitis. So we need to be mindful of that. That is why we take proper history when you examine, you know, listening to the chest to ensure, you know, that if there are crepitations, transmitted breath sounds, you know, then you want to use your antibiotics to take care of that, because all these comorbidities can even worsen the outcome of stroke, you know, and complicate matters. And then, of course, we're talking about the patient as a whole. this person has diabetes, this patient might have other conditions going on that needs to be addressed. We've talked of heart failure. There are other things this patient will present with that needs to be addressed apart from stroke. Then of course we talk of nutrition. That's why we talked of the NG tube, you know. With these patients, especially those that are unconscious, they need to be fed properly. So that's where the dietitian come into play, because this is a multidisciplinary approach. It's not just the neurologist that are involved, the cardiologist is there, you know, the dietitian comes into play, the physiotherapist come into play, you know. This is, it's a teamwork. So the dietitian is there to advise on balanced meals for this person that can't feed, you know, normally. Then, of course, the physiotherapy. We talk about physiotherapy and we say physiotherapy should be done immediately. As soon as this person has come with hemiparesis, we need to start sorting out physiotherapy as soon as possible. So for the blood pressure control, this is very, very, very important. And the reason being that a lot of time they come in and our focus is just on the blood pressure. We've forgotten to look at the person as a whole. So once they come in and we're already suspecting stroke, and we then do our brain CT, and it tells us it's hemorrhagic, it's ischemic. So we now know that, okay, for hemorrhagic, for ischemic stroke, there's something we call permissive hypertension. We've talked about the ischemic penumbra, and we've mentioned how we want to see how we can preserve those areas that are ischemic, but not yet, there's no infarction yet, you know, how we can preserve it, to see how this patient can pull through better rather than worsening things. So we say our target blood pressure, especially for that first 24 to 48 hours. If it should just be between less than 220 to 120. Some people say, oh, this blood pressure is high. But remember what we discussed in the pathophysiology about the autoregulation. The brain is already used to that pressure. And if you cut off that pressure, you're going to worsen that area that has been opened up with high pressure through the collaterals to help perfuse the penumbral region. So we are mindful. The blood pressure for ischemic, as we said, ischemic, we've made that decision, we've gotten a brain CT. That's why it's so important. Once you're managing stroke, you need to see a brain CT. Some people will say from the history, you can guess whether it's ischemic or hemorrhagic, but it doesn't always play out that way at times. Sometimes what you're thinking is hemorrhagic might just be ischemic, maybe just a wide infarct, you know. So it's important we get a brain CT done. So once you're dealing with a blood pressure that high, we allow that permissive hypertension. And then the preferred antihypertensive we want to use at that time to help give a controlled blood pressure that you can monitor is IV labetalol that is readily available. You can use your nicardipine IV, but labetalol is readily available. That we can give, and then we can control it because it can also be given as an infusion apart from the initial bolus if the blood pressure is greater than this 220, 120 we've talked about. So once you are seeing somebody coming with a blood pressure of about 260, we've had a case like that. 260, because the person was just on the monitor, because if we were going to use the mercury's figure, I doubt we'll be able to get that value. It was already on the monitor, we could see it clear as it was just beeping at us, 260 over 170, you know. So that you can start with your labetalol. Please, we don't do sublingual nifedipine. It's a no-no. It's not used to be. It has an erratic way of bringing down blood pressure that will further worsen and cause a sudden rise after a while. So we don't want sublingual nifedipine. So what we want is that once we can control IV labetalol, and it's an infusion, if we see the blood pressure is going lower than we want it, so we can stop, we can reduce the flow. It's controlled. So we want something we can control, especially that golden period of 24 hours. So subsequently, after 24 to 48 hours, then there's room to introduce. That's why we said the NG tube is there. So even if the person is unconscious, we can still give our oral medication. So after the 24, 48 hours, then we can now put in any of the other antihypertensive to gradually now bring down the blood pressure. But something is also very key and very important in stroke management. And we don't really get to do this as much as we should. That is giving thrombolytics. So fibrinolytic therapy is also important. But what we realize is that a lot of people don't come in on time. Sometimes they would have gone to, the part that is even worse is when we hear, we did not even know for how long the person has been unconscious. The person was just found unconscious, you know, or maybe just they tried waking up the person and that was it. So maybe it happened during the sleep. You know, for such cases, you know, probably it has happened. You can't tell for how long it has happened. You know, people go to a lot of places, they are there struggling with blood pressure, only to, before they finally get to you, you realize that time has gone and they've missed that golden period. Sometimes it's a process of getting the brain CT done before we, because some, and they always come at night. You know, there's just this thing about, they just come at night, you know, and that is when you're trying to sort out brain CT. Even your center, you don't have a brain CT facility, as you have to now transport, you know, all those delays at times can, you know, really be frustrating. But, you know, where it can just be done properly and within the maximum of 4.5 hours from onset of symptoms to when you are seeing this patient. You know, within that period, you're able to make a diagnosis and you are sure it's ischemic stroke. Definitely, you would have ruled out all the contraindications to thrombolysis. There is room for giving Atteplase or Tenecteplase, which is a fibrinolytic agent, which will just go in there and help lyse the clots and help to improve the neurological deficits. And it does work when you are able to do it within that window period of 4.5 hours. Beyond that, there's no more benefit anymore. Rather, there's more risk of bleeding. So if we can get this patient during this period, it is very good. But we should also remember, before we give thrombolytics, we need that blood pressure target to be less than 185/110. So in this situation, even when it's ischemic stroke, because you want to give thrombolytics, this is now your target blood pressure. So you want to bring down that blood pressure to this level before we now give our thrombolytics. But if you know we are not going to give thrombolytics because of whatever reason, it's quite expensive. I don't know if people readily have access to these things, because when we talk of Tenecteplase, some people have never seen it before, or when they see it, you will know how much it is with this economy right now. It's not easy, you know. So if they can really afford it, it's really good. But if they can't, then we are talking of that permissive hypertension. But we should always remember that before we give thrombolytics, if the person fits into that window period and is an ischemic stroke with that blood pressure range we talked about, we need to quickly rule out the contraindications. So if you're dealing with, so these are things you should have picked up from the history quickly. You know, if you're, of course, the severe uncontrolled hypertension, that's why we said the blood pressure should be reduced. So those ones, we can control the blood pressure. But if the person has had a recent ischemic stroke, especially within 3 months, you might not want to give thrombolytics. If the person has had a history of hemorrhage, you will not want to do that. You know, person has history of maybe trauma, surgeries and all that, you know, we need to be careful, especially recent surgeries, you know, thrombolytics might be an issue. And then, of course, we have relative contraindications where you now ask yourself, does the benefit outweigh the risk of giving this, you know? So going beyond, okay, well, if for whatever reason we missed that golden period, you know, we've talked about the blood pressure control, the medications we'll prefer. It's always important to check this sugar because, as she has said earlier on, you know, this person could just be dealing with an hypoglycemic issue here, you know, that is worsening the conscious level, you know, and then you would now need to correct. But we should also remember that hyperglycemia can worsen prognosis. So we don't want any form of this is not whether you are diabetic or not. Once we check that sugar and it is elevated, you want to bring it down with our insulin, at least during that acute phase, because that acute phase is a golden period. That's why some centers even have stroke units, like a part of the hospital that is like an ICU, but just for stroke alone, for that golden period of about that, when we are talking about acute management of this patient, maybe the first 7 days, because a lot of things can go wrong and you need close monitoring. Then, of course, all of this is also done while this patient is also in the ICU. You are checking the sugar regularly and you don't want hyperglycemia. Then, of course, antipyretic medications come into play because they can present with fever. As I said, they can also have sepsis. So, you know, you want to address every other thing concerning this, this patient. You know, if there's sepsis, you want to take care of sepsis. You want to give any of the antipyretics you want to take care of that because that will worsen prognosis also. We've talked about hyperglycemia, a stroke associated with worse outcomes, so we need that sugar to be controlled, and preferably what we use is insulin or GKI, whether they are conscious or unconscious. At that point in time, we're not talking about oral anti-hyperglycemic agents, oral anti-glycemic agents. What we want is insulin, or if the person is not tolerating well, we can do our usual GKI where we use a 5% dextrose with potassium and insulin, depending on the sugar of that guest, and then you can titrate and monitor closely. Then, okay, we've talked about blood pressure. You know, we've said this over and over, and it's so, so important because at times we get to see patients that the blood pressure was crashed. Somebody has presented with hemiparesis. In short, sometimes they don't pick that history of slot speech. All they've just picked is elevated blood pressure, you know, and everybody said, oh, maybe it's hypertensive urgency, but they've not taken their time, you know, to really take a detailed history, and you miss that and you just crash that blood pressure. Or even when you know it's stroke, so people are like, how can the blood pressure be 200? They're bringing down the blood pressure. And at that point in time, the neurological deficit worsens, you know. So we'll keep saying this over and over when we see our stroke patients, because sometimes we see them first before we can transfer to centers where they can get more expert care. You know, what do we do first is so important. That first treatment, wherever they get to, you know, it's so important because that determines what happens next. If it goes wrong from the very beginning, you know, even when they get to the best of centers and they be mismanaged, it's now difficult to even fix or readjust what has been damaged, you know. So that's why we keep talking about this golden period, and we should be mindful of blood pressure and bringing it down. Then, of course, this is a dose of IV labetalol. And as I said, the good thing is that it can be titrated, so we can give and it can be controlled, and we can tell when to stop, you know, and when to allow. But after 24, 48 hours, some people just leave the 48 hours and like, okay, after that time, then you can put in all your usual antihypertensive to control the blood pressure the way you want to, the usual way. But when we talk about hemorrhagic stroke, before we go into hemorrhagic stroke, we would want to talk about cardio care. We have the public relations team. Hello, so we want to talk about cardio care. Just give us some few minutes. We'll come back to complete the many aspects of stroke, but we also want to tell you what we are all about, the LIMI Hospital, the cardio care group. We have the Children's Hospital, we have the LIMI Hospital also. And then in cardio care, we do a lot of procedures. We put devices, the CRTs, the ICDs, we do coronary angiogram, and percutaneous coronary intervention. We put pacemakers. We run a multidisciplinary approach to things here. We have consultants covering every aspect of medicine. So we'll go into more details about cardio care. And we talk so much about this so that when you see your stroke patients, you can always remember to refer to us. When you see other cases, either cardiac or non-cardiac, you can always refer to us for expert management.
Thank you all for joining in. It's been an exciting time here. So briefly, I'll be talking about James Emmanuel, the public relations manager of the LIMI Hospital. So briefly, I'm talking about Cardio Care Hospital. Cardio Care Hospital is a subsidiary of the LIMI Hospital. Our focus is beyond service to Nigerian populace. Cardio Care is an indigenous cath lab practice and cardiovascular hospital We are into local research. We train and we give exposure to medical professionals also. But our main aim is to reverse medical tourism. We do healthcare collaborations and partnerships. We host strategic outreaches that offers life-saving interventional procedures to indigent Nigerians. So, um, what we are known for, we establish robust intervention with the hopes to many as possible. You don't need to travel outside the country anymore. We want to make it as accessible as bread. So I say it again, as accessible as bread. So we want to curtail medical tourism. What you are looking for outside is here in Nigeria. So why traveling and spending so much money for something you can do here in Nigeria? So Cardiac Care Hospital, we are located at number 5 Giza Close, right in Abuja. Cardiac Care is 60 minutes away from every part of Nigeria. If you're taking a flight from the east, west, north, south, it's just 60 minutes. Cardiac Care is wholly dedicated, we are wholly dedicated to comprehensive cardiovascular and internal medicine. We have received multiple awards for excellence in service. So here are the services that we do here at Cardiac Care Multi-Specialty Hospital. We do interventional cardiology. We have a functional cath lab. We have done over 900 cases so far. Cardiology, nephrology, neurology, rheumatology, pulmonology, critical care, cardiothoracic surgery, general internal medicine, and so many other more. So, what I consider Cardiac Care Multi-Specialty Hospital? Number one, we have a team of excellent care. We also get or requested. So when you refer back, referral, referred from, then we can collaborate. We can discuss opportunities to the cath lab for procedures and see how it's been done, and also participate. We are open to that. We also run a 24/7 emergency, same day, next day appointment. So you can reach us 24 hours, 7 days a week. We have no holidays here at Cardiac Care. So far we have done over 500 successful cath lab cases for pacemaker, CRTs, coronary and peripheral revascularization with stents, IVC filters. So while awake with no scars. So these non-invasive procedures you can do it for your patients while they are awake. And so as you can see on your screen, so I'll talk about our experience before I hand over to our consultants. We have done a total of 900 procedures. We carried out 600. It was carried out on 602 patients for over the last 3 years, with a ratio of 2 to ratio 1. So males more of the patients we have dealt with. So the mean age is 59. So basically, Cardiac Care is open for referrals. We also do symposiums. I'll be using this opportunity to invite us to the 80th edition of the Abuja Cardiovascular Symposium. This year's edition is, as you can see on your screen, our team this year is sorting cardiac death, cardiovascular care algorithms. So we'll be taking time. It's a 2-day event starting from the 5th to 6th of December here at Abuja. We'll be taking time to teach basic life support. We teach you how to read an ECG. You register now. So for you to register, you go to www.cardiologist. For you to register, it's just going for as low as 10,000 naira. We'll also be feeding you. With the way Nigeria is, we'll also be feeding you. We'll be giving you breakfast, and we'll be also giving you certificates. We're in partnership with the Nigeria Cardiac Society. So I want you to register. It's going to be a great one. For those who have participated before, I'm sure they will want to participate. I will need all this. And you can get them to register. You can also reach out to me if you're having issues. You can see the number on your screen, 090-9436-9526. Much for your time. And before I hand over to them, I'll take on how you can refer to us if you have cases that you need to refer down to cardiac care. As you can see on your screen. So basically, you can refer to us by calling any of the phone numbers on your screen, or you send us an email to frontdesk@cardiocare.ng.
Thank you.
I repeat, frontdesk.
I guess we are still all there. So
NG.
while we're trying to change the slides, I'll just quickly try to address some of the questions that came up. Somebody was asking how much fluids do we give. We've talked about the stroke. This is stroke, regardless of what you're dealing with, whether it's ischemic, hemorrhagic.
Thank you so much.
We talked about 3 liters in 24 hours of normal saline. But of course, you know, we said we're looking at the patient as a whole. You might give patient A 3 liters, another patient A might not have 3 liters because of maybe a cardiac issue, you know, because if somebody is coming in with heart failure symptoms, pulmonary edema, that's not the person you also want to give the same 3 liters. I say, it's stroke, let's give 3 liters. So as much as we're saying 3 liters, it's also subject to the person you're saying, and you're looking at the person as a whole, you know. For the very elderly ones, you know, you don't want to flood their lungs, you know, so you need to be careful. As much as you're saying 3 liters, you know, after maybe a day or two, you might want to step it down, especially if you're tolerating well orally, you know, for especially the elderly ones. But normal standard, we are talking of 3 liters in 24 hours, and the patient would always be on it throughout that acute phase, as long as the patient is still on the ward, you know. Then somebody was talking about, asked a question on dexamethasone. We use mannitol for stroke patients, those with cerebral edema, you know, because most of the time the CT scan will tell us, yes, you're dealing with cerebral edema. So yes, we use mannitol for those patients. There's a different thing if you're thinking of a space occupying lesion, like if there's a tumor and all of that, then maybe your DEXA might come into play. But for the stroke, what we are presenting, what we are talking about is mannitol. And of course, we've talked about the other benefits of mannitol, that mannitol also even helps in reducing the blood pressure. So when we are still talking about medications, while we're still talking about medications and all, you know, you can start off with your mannitol. That's medications, your antihypertensives. You can start off with your mannitol because it will also bring down the blood pressure. It will also bring down the blood pressure. Then, what question did we see? I think that's okay. Somebody was also asking the question on labetalol. Yes, that how do we give labetalol and all that? That is already, you would all get the slides after the presentation to be sent to the emails that has been, as long as you've registered, we'll always send it to you. So you get it. It's there. Labetalol is readily available. And we don't forget, we are not rushing to give labetalol. We've talked about the permissive high blood pressure. In ischemic, we've not gotten to hemorrhagic yet, we are still on ischemic, so that we don't mix it up. Ischemic, that permissive blood pressure. And that permissive blood pressure, it's within 24 to 48 hours, we allow that. But if it's going beyond 220, 120, even in that first 24 hours, we still have to bring it down a bit, But if it's just, it hasn't gotten to 220, it's still elevated, we are good. Subsequently, after 24 to 48 hours, then we can put in all our antihypertensive. And we said the preferred IV antihypertensive in that acute phase, when we think it's going beyond the 220, is our labetalol, because it's controlled, it's short acting, we can stop it at any point when we think that the blood pressure is going too low, because we don't want to worsen neurological deficits, So this is the dose. We start with the bolus, and then we can now titrate using 100 milligram in 300 mils. We use our syringe pump to do that. And then we're able to control it at 10 mils per hour, but we don't exceed 300 milligrams in fast. By the time you start your 10 mils per hour, you see the blood pressure is already reducing to about, we're getting about 180-ish, and we just leave it there. Sometimes we then stop and restart or reduce the flow rate and stuff like that, especially that within 24 hours. But subsequently after that, then we can give all the other antihypertensive we are used to, our ACE inhibitors or ARBs, our calcium channel blockers, whatever other medications you want to give. At that point, you can do that. But of course, we said gradually, we are not just knocking everything off. We're just starting gradually. This patient is being monitored in the ICU. So at every point in time, this patient is being, the decision is taken, you are monitoring closely. You want to add this weight for a while, see the blood pressure results, what the blood pressure is saying before you add the next. So addressing all of that, now we can now move to hemorrhagic. So we said the only way we can make this diagnosis is by brain CT. Let's not use history and just say, oh, there's seizures, maybe it's hemorrhagic, because we know at times we used to do that, especially when you are struggling with brain CT or someone says, I cannot afford it, but we don't want to make a mistake, because we're talking about someone's life here. And, with neurological deficits, it's not easy, because they are left for the rest of their life with reduced quality of life if we are not careful, So we want to try as much as we can to preserve all that we can preserve, So, as I said, we've talked about ischemic. Now for hemorrhagic, it's a different ball game entirely. I say, once you just see that brain CT, you just see that white thing, just know that it's hemorrhagic. Depending where they cover reports, depending where they give us all the full details of the whole stuff. But most of the time with hemorrhagic, you now have cerebral edema, because of wherever you have the blood, it's irritating, they have edema around there, So with that blood pressure needs to come down, because we know that it's that high pressure that has burst the arteries and there's bleeding around there. That BP has to come down. So this one is no permissive hypertension anymore. We are not permitting anything again. The blood pressure needs to come down. But remember, the coming down is not crashing. We are bringing it gradually, because there's still that auto-regulation thing going on. But this time around, we don't want to worsen the bleed, because the more pressure, the more bleed. It's keep bleeding. So now we want to gradually reduce it. And we've talked about blood pressure reduction, 20% in 24 hours, and then subsequently, now continue reducing it gradually until our target of 140 systolic. So the 140 systolic, you might not get it in 24 hours, but at least you get your 20% reduction. So if somebody comes in with 200, well, let me say, for example, 180 over 100, we won't say, oh, it hasn't gotten to 220, we'll leave it. No, this is hemorrhagic, we'll bring it down. But we don't want to bring it down too low, because we just want a 20% reduction in 24 hours. Then after that, you can now bring it down to the normal, but not to exceed 140, because we need to be careful, because we still want good perfusion in the brain, as much as we want to control it. And these are the agents, and these are the preferred agents, because we can control these drugs. And labetalol, we keep saying labetalol because it's readily available. We are not looking for it. Because if we start talking of nicardipine, I've not seen nicardipine before, but labetalol is everywhere. We can control it, we can give it at a controlled dose, we can stop, and we know that the blood pressure won't go further and things like that. So for hemorrhagic, we've talked about other medications we give for ischemia, but we should be careful with hemorrhagic, because there's a bleed. This is not the person you want to give your aspirin to, because we know that we give antiplatelets in ischemic stroke. Either you do your clopidogrel or you do your aspirin. But in this setting, in hemorrhagic, you don't want to do that. And then for them, because we can't do your usual DVT prophylaxis of giving clexane, like we would normally do clexane, that's enoxaparin, or we do our heparin. Because we can't do that, especially in the first few days of hemorrhagic. You now need to use your pneumatic compression device. We're not talking of TED stockings, so this is pneumatic compression device, the ones that will actually pump and ensure there's good venous return, you know. So that is what is preferred for them. And of course, physio as soon as possible, because these patients are not ambulating, especially when you're dealing with hemiplegia. Most of the time they are in bed throughout. So you need to ensure physiotherapy, even if it will be passive initially, but they need some form of physiotherapy from the onset.
Or can we use TED stockings as well, especially for those people in their center? Maybe they don't know. Maybe they don't even know what pneumatic compression device.
No, but it's not effective. We've said that it's not effective, you know, because TED stockings at the end of the day is just sometimes they don't even get it right, and then even when you get it right, it just feels like socks. But that compression pneumatic stock actually would compress, because the whole idea is to reduce stasis, you know, so you can actually compress, push the blood back up, you know, and then relax, push again. So it actually helps mimic the actual venous return that you should expect, as compared to the pneumatic, the usual TED stockings that just sucks. They just have it in there, and it's not really, it hasn't shown to be so much benefit, especially when we're talking of DVT, because the whole idea is to prevent DVT. That's what we're trying to prevent here. And once DVT comes into play, we are dealing with pulmonary embolism. Once there's pulmonary embolism, the story changes. So, you know, we are
people wear TED stockings, they are not covered.
So now we'll talk of subarachnoid hemorrhage. You know, when we talk about the bleeding, we said there's intracerebral hemorrhage and then there's subarachnoid hemorrhage. So with the subarachnoid hemorrhage, sorry, there are two complications we're worried about. You know, the two complications of subarachnoid hemorrhage that most contribute to morbidity and mortality is that rebleeding and vasospasms. And thus, blood pressure control is important in them. So it's just like the same bleed. Once there is blood, that BP should come down. 20% mean arterial pressure, first 24 hours, subsequently, it should return to about 140 systolic. Some will say 150, but we want it to just be around that 140-ish. We don't want it to go to normal level yet within that 140, so that there isn't too much pressure to increase the bleed, and it isn't too low to reduce neurological deficits. And we're trying to avoid rebleeding, vasospasms that will worsen the situation. So once we talk of bleed, subarachnoid, that's intracerebral hemorrhage, subarachnoid hemorrhage, that is the same BP control. Patients with acute subarachnoid hemorrhage often require blood pressure monitoring via arterial line as well as ICP monitoring, but when it can be done, we connect to the cardiac monitor. The BP should be monitored closely, because these are people that might seem stable, but they can just dip at any moment, you know. So we need to monitor them closely. Blood pressure glues are like, as we said, intracerebral hemorrhage. So it's same thing. And here there's need for nimodipine because it helps with the vasospasm, you know, which can worsen mortality and morbidity. Another factor we need to talk about is cardioembolic stroke, because when we talked about ischemic stroke, remember we said there's the embolic and the thrombotic part. So the embolic part is that's where we're talking about the cardioembolic stroke. And approximately 20% of ischemic strokes are considered cardioembolic. We get to see these guests a lot. You know, sometimes they come with repeat stroke. So there was even one we had recently, had 5 episodes of stroke, as in at different times. So by the time we were seeing was the time the guest had the 5th stroke, you know. And, you know, by the time we took the history, we were wondering, why has this person been having repeated stroke and all of that, you know. The person had a bowel prosthesis valve in situ, you know. So we're like, oh, are we dealing with infective endocarditis? And then we did the echo. What we saw was aortic aneurysm. By the time we did the aortogram, there was a dissection, and that was, you know, that already answered our question. So, you know, so by the time you're seeing people coming with repeated stroke, we need to probe further. What is causing this, you know? So you need to ensure that proper history is taken, proper cardiac evaluation is done to rule out arrhythmias. That's why we talked about the Holter, because with the Holter, our ECG might not pick paroxysmal atrial fibrillation, but by the time we do the Holter of 24-48 hours, it could just pick intermittent atrial fibrillations or atrial flutters coming in, and you know those patients will benefit from anticoagulation. So you need to pick it, because the whole idea of anticoagulating is because you want to prevent a stroke, and then they're not coming with stroke, they are at risk of another stroke again, you know. So we need to pick these things. You know, by the time we've talked about in the examination, if they're having murmurs, you need to probe further. By the time you do the echo, you're seeing valvular issues and all of that. And by the time you're thinking of mitral stenosis, you know, moderate severe, you're thinking of anticoagulation. Sometimes they come with mechanical valves. You want to ensure they're adequately anticoagulated, you know, with warfarin. That's if they're coming with their mechanical valves, because if not, they can have a cardioembolic stroke. So these are the things we are looking out for in these patients. You know, those that come with congestive heart failure, the concern is that their chambers are dilated. The left ventricle is so dilated, at times they have clots in there, you know, and that clot can go and then through the, what's it called now? The carotid, it goes to the, either the anterior or the middle cerebral artery, and then we're having an embolic stroke. You know, so when we're taking history, we are paying attention to these things because their mode of management is totally different. Because with this ones with cardioembolic stroke, they're thinking there's a clot, you know, from the heart, you want to anticoagulate. Then, of course, you want to rule out other concomitant diseases that they can present with. So hemorrhagic infarct or multiple arterial infarcts will be seen on CT or MRI. These are the ones that you might see multiple infarcts. It might not be just a segment affected. It might be the frontal, parietal, you know, or you are seeing it in your occipital. You're already wondering, why is it scattered all over, you know? Yes, it's of vascular origin, but it seems like it's hitting different territories. You know, you want to ensure that you rule out a cardioembolic stroke, because for this ones, you know, you need to place an anticoagulant. It's different from ischemic stroke where you just give prophylactic dose for the DVT. But with cardioembolic stroke, that is as a result of an arrhythmia, like atrial fibrillation or atrial flutter, or there's a cardiac clot and all that, you would want to give them anticoagulants. So there's room for surgical management where it is available, where you can do it, you want to give surgical care. And for ischemic stroke, where it is done, there's room for something called mechanical thrombectomy. But there's a golden hour to reach. First 24 hours. The earlier, the better. You know, some even say that a presentation of less than 6 hours, we should be able to do mechanical thrombectomy, where you're able to go in directly is, you know, interventional study. You go in directly, you get all the way to the cerebral artery, you're able to bring out the clots, you know. So you're mechanically removing out the clots. But there's a window period for it. But how many people can present during this time is an issue. Are they able to get to the facilities where this will be available is an issue, but we should know there's this available so that where you're in centers or places where you can get this done, you can take advantage of it. Then for those that come with intracerebral hemorrhage, there is room for what we call ventriculostomy, because they can also come with obstructive hydrocephalus. Sometimes intracerebral bleed is so much, it's into the ventricles, it's causing obstruction, and they are at risk of coning and all of that. So you might need to divert CSF elsewhere. So that's when you do the ventriculostomy. Then for the subarachnoid hemorrhage, those that come with aneurysmal subarachnoid hemorrhage, there's room for clipping and coiling for that.
And so just to give an expo about the case that we gave in the beginning. So the woman actually had an hemorrhagic stroke, and she actually had a ventriculostomy done, and she did well on that. So that's
life experience.
Yeah,
you know, these are the cases we get to see.
Yeah, so it's actually possible. These things can be done, and they improve, you know, outcome of patients. Okay, so now talking about the complications of stroke. Now, medical complications from stroke account for 50% of mortality in the first 1 week. So this is to tell us that we, apart from, you know, identifying stroke and managing them appropriately, we must also know about these complications which can increase mortality in them, so that from the outset, we are looking out for them, and we are also putting measures in place so that they don't develop these complications. So the first one is cardiac arrhythmia. Like we have said, anybody with a stroke should have an ECG done. So if they have an ECG done and we continue monitoring them with ECGs, we can identify any cardiac arrhythmias, and even MI, they can even develop MI after a stroke. So it's important that we monitor them with ECG so that we can detect and manage cardiac arrhythmias when they develop. And then another important one which we have talked about is DVT. and subsequent pulmonary embolism. And that is where the DVT prophylaxis comes in, which is very important. So we need to know that if we don't put that prophylaxis in place, these patients, after we may have managed them, maybe they've even survived up to a week, and then we now lose them to something like DVT or P. It's not the best. So we really need to put it at the back of our minds and do everything possible so that they don't develop these complications. And another complication is infection or sepsis. So for people with stroke, they are prone to certain kinds of infection. For example, pneumonia, usually from aspiration pneumonitis, just as we said earlier. So some of them develop aspiration pneumonitis, and from them, there they develop pneumonia, and we have to be on the lookout for this and manage appropriately when we see. Then we can also have urinary tract infections because, you know, some of them you have to pass catheters, indwelling catheters, and then because they are immobile, all these things can contribute to UTIs in them. So we have to be on the lookout and manage those appropriately. Then we've talked about aspiration pneumonitis. Then dysphagia. We talked about dysphagia as a common presentation. So because of that dysphagia, malnutrition can also occur as a complication. And then seizures, just like we have said, maybe at the acute stage, it could either be at the acute stage or later, because that in fact will now become a focus, and then they can now develop seizures or even epilepsy after a stroke. So we also need to watch out for that complication and treat appropriately. Then decubitus ulcers is another thing, especially for those who remain maybe unconscious for a long time, or they have dense hemiplegia, they're not able to move and they're not turning them. So they can develop decubitus ulcers. So this, we must put this in mind and make sure that when we have unconscious patients, we're turning them as often as we should, and we look out for this so that they don't end up developing decubitus ulcers. Then depression is another complication. You know, people with stroke, at the end of the day, they may develop a disability, and then from there, that could be a risk factor to tilt them into depression. And therefore, those that maybe already had maybe a previous history of depression, or they have poor family support, that could really be a risk factor that can tilt them into depression. So we need to be on the lookout for that. If our patients develop that, we need to be able to provide them with the psychological support that they need. Okay, so now we'll take a second case, the case of Mr. UC, a 78-year-old man, known heart failure patient with atrial fibrillation, presenting with loss of consciousness of 12 hours prior to presentation. He had no seizures, headache, or vomiting. He had a previous stroke 2 years before presentation. On examination, he was unconscious. GCS was 11/15. Power on the right upper limb and lower limb were 2/5. Pulse rate was 108 beats per minute, irregularly irregular. BP was 180/100 millimeter mercury. JVP was elevated. Apex beat was at the 6th left intercostal space, lateral to mid-clavicular line, and he had first, second, and third accents. So this is the brain CT of the patient. And then,
so we can see the hypodense areas. So I hope we can appreciate it more on the right. So let's answer, please. What do we think?
So should we give antihypertensives? Should we give alteplase? Is it an hemorrhagic stroke, or is it a cardioembolic stroke?
Let's remember the key words that this person is presenting. We're still in the 24-hour period, 12 hours presentation, has had a previous stroke, so we are already wondering what's going on. There's background heart failure, atrial fibrillation, you know, so, you know, we said we're looking at the patient as a whole. It's not just, oh, the person has come with a stroke.
Yes.
But if you don't ask this question, sometimes they won't give us this information. You know, we need to ask the caregivers who has brought them, what else do you know about this patient? Because that will guide us to know what to give for this patient, or how to determine what type of stroke we're dealing with. And then, of course, if we don't do a thorough, quick examination, because, you know, this is an emergency, we want to quickly make a decision, so we want everything to be quick straight to the point, and then when person is on the when person is in the ICU, you can now do a full history, but we need to get important things to know what to move on with. So with that, what are we thinking of? A, B, C, D. Please, can we put it in the Q&A or the chat box? Anyone? Just let us know what you think. Okay. Okay.
That's from 3 people.
Okay. So we are happy because we're making good diagnosis, you know, because that changes the whole thing. Because, you know, this is a patient that would benefit from anticoagulants alongside all your other medications. We know that this patient, when it comes to BP control, you know, you already know what to do since we are still in the first 24 hours. And for this patient, you need to be careful with fluids, as we said. Even though normally we would have done 3 liters, this is elderly, the person has heart failure, you know, so you don't want to overload the lungs, you know, so you need to be careful with fluids. You might not give up to that 3 liters, but you know that you must try to give enough fluid even through the NG tube to compensate for the ones you can't give IV, you know. Then so what are we worried about when we talk of stroke management? You know, aggressive early treatment of blood pressure. We've said this over and over because we see it a lot. We see those presentations, and by the time they get to us, we've heard, you know, even it's written in the referral letter, we've given an Aldomet. There was one that came with the sublingual nifedipine still in his mouth as a presentation. You know, we're still trying to do the NTG spray. You open this mouth and which a drug dropped out. We're wondering, what is this? You know, and then it was a sublingual nifedipine. You know, and we've said this over and over. And this was the guest that said came in with very elevated blood pressure. You know, so it's still happening, and we keep saying it. Please, when it comes to blood pressure control, if at all you would have to bring down that blood pressure because you're going beyond your 220 mark, you know, then preferably use your labetalol. Somebody asked a question that do we that what if you don't have labetalol? I think person was trying to mention where he or she is or something like that. There are other IV antihypertensives we talked about. Remember your mannitol, we mentioned it. Mannitol also brings down blood pressure, especially when you're dealing with a hemorrhagic, you know, stroke. Because of course the cerebral edema, and you know the mannitol with and you know with mannitol you're giving laces also alongside, so that will also bring down the blood pressure. Most of the time, by the time we start with mannitol, we might not even get to the use of the antihypertensive that 24 hours, because your mannitol is giving, apart from the start dose, you're giving 8 hourly. So after every 8 hours, there's something going to be given to bring down that blood pressure, you know. So there's room for that. You know, there's also room for hydrelazine, although we need to be careful. But we keep saying labetalol because it can be put in an infusion and titrated appropriately. So another thing, again, we are mindful of is hypertensive encephalopathy, because sometimes it's misdiagnosed. You know, you think it's supposed to be hemorrhagic, or somebody thinks it's hypertensive encephalopathy. And if it's hypertensive encephalopathy, we know that that is more of a hypertensive emergency, you know. So you just bring it down, bring down the blood pressure, and the worry is that you've missed out the stroke. So we need, that's why good history and then your brain CT, it's important. Then adequate hydration. Hydration alone helps also with perfusion. So let's ensure that this patient is well hydrated. Let us not say, oh, you know, IV fluids, just look at it like, it's not normal saline. It's not just normal saline, we're hydrating, you know, so it is very important. 3 liters, adequate hydration. We've talked about hyper and hyperglycemia. If you don't check, we wouldn't pick it, you know, and we think, oh, this unconscious level is because of the stroke, not knowing that it's just hypoglycemia. Just correct the hypoglycemia and we are okay. Somebody presented in the emergency. The random blood sugar was about 1.9 or so, there about almost like 1.9 or 2, if I'm not mistaken. In short, when we saw it, it was like, is this glucometer working? You know, this was very, very, and the person came unconscious. You know, if we hadn't checked, we would have, oh, you stroke, we are taking for brain CT, you are doing that. God forbid, you know, the person would have just, you know, the story would have ended even before you move out, you know, but just checking, and then immediately we started our correction. It was like magic. Immediately the person conscious level recovered, you know. So we keep saying this hypoglycemia, glucometer, that one is readily available, you know. Then of course, complications for stroke. If we don't look out for them, you know, we won't pick them. We've mentioned all the complications. We need to look out for them and address them also, because that could be the problem. not even the stroke itself, and then it will worsen condition, you know. So when we talk about secondary prevention of stroke, we also need to remember that after this patient has done well, the person has gone home, or before even the person goes home, we need to counsel, educate, let the person understand the person has had a stroke, and we need to ensure these parameters are properly controlled. BP has to be controlled. You've had a stroke before, you can have another stroke. So you need to ensure that BP is always controlled, even when you're seen on outpatient basis. Sugar, you keep checking, it's well controlled. Statins, we've talked about statins, regardless of what the lipid profile is. High dose statins you must use. We said atorvastatin either 40 milligram or 80 milligram, or rosuvastatin 20 or 40. Then antiplatelets, we said it for ischemic stroke, they should be on either aspirin or clopidogrel. And then, of course, when you're thinking of a cardioembolic as a result of atrial fibrillation, flutter, or clots in the heart and all, then they need to be anticoagulated. Lifestyle modification, that's a general thing. We don't want sedentary lifestyle as much as possible. Your body mass index should be within the expected range. No smoking, no alcohol, So rounding up everything, we should remember hypertension is the major issue here, and it's something we can control, it's something we can address. If we can avoid that from happening, that's one of the major causes of stroke. There are other causes, yes, but hypertension is one thing that's major in stroke, and it's modifiable. So when we are seeing our patients with high blood pressure, let us ensure that the person is not just taking medications, but the BP is within the normal range, because we get to see a lot of that. I've been taking my drugs, but by the time you check the blood pressure, it's elevated. That's as good as not even taking medications, because we've not done, the blood pressure is still high. Then we've talked about the be fast. It's something that anywhere in the village, wherever, you should just know these things and know how to immediately send the person to a center where the person can get adequate care. Then, of course, we talked about differentiating ischemic from hemorrhagic, because the management totally differs. And we've talked about secondary prevention. So, of course, cardio care. We've talked so much about cardio care. I think we've addressed all the questions. I don't know, I can't see any other question that has not been addressed along the line. We checked and we tried to address it while we were talking. I don't know if any more questions are coming in. I can't see any more questions. So we are told, remember, you can always refer, you can always partner with us. Once you send your patients to us, we'll always give you feedback. We'll let you know what we've done and what we expect next, what follow-up should be like for the patient. So we always send this feedback. So we do a lot of that. So don't hesitate to send your patients to us, and then we'll always tell you what we've done, because we send the patient back to you once we are done. And we want to also use this opportunity again to remind you that we have our 8th Abuja Cardiovascular Symposium coming up on the 5th to 6th of December 2024. That's in less than 2 months, about a month away. So please, let's start preparing, let's register. It's always interactive. We get to see everyone in the Limi team. We get to answer questions. We get to deal with burning issues in medicine. The team this time around, the sudden cardiac vets, we dissect ECG very well. We talk about everything we should know about sudden cardiac vets, and basic life support, our BLS, ECLS, advanced life support, and all of that. We always talk about and practicalize it. I'm sure a lot of you on the team is also part of us, as they always keep to the ACS every time. So we're inviting you again. So please register and then prepare, so that we see there 5th to 6th December 2024. We're still checking if there are any questions. If no questions, we'll then call it a day. Somebody is asking what's the best anticonvulsant to use. So when the patient is unconscious, yes, we do our phenytoin or there's room for levetiracetam, but that is oral. So we can pass it through the NG tube. So either one of it. But remember, you have your diazepam to abort the seizures. But there's room for phenytoin, that's an IV, and then levetiracetam can be given orally via NG tube if it's unconscious, or orally if the person is conscious. Then we have a patient last week that came with a BP of 160/110, which I would say was an incidental finding, and the presenting complaint was restlessness. So what's the question? I'm not too sure I understand. What's the question there?
What diagnosis is
What's that? Because you need to probe further though. Incidental finding, are you just dealing with just hypertension, or there's more to? That's why I said history. History. You need to ask those questions to know if you're dealing with hypertensive urgency or emergency. Urgency, there is no end organ damage. There's no other complaint, just elevated blood pressure. Hypertensive emergency, that we talked about it extensively. I'm sure our videos are on YouTube, last month's webinar. So if it's emergency, then you know there's signs of end organ damage. You'd have asked signs of maybe the person is having a left ventricular failure. Is there signs of encephalopathy? Because when you talk of restlessness, is there irrational behavior? When you say restlessness, it's a relative term. What precisely? Is the person aggressive? Is the person irrational? Things like that.
There are a lot of things you have to
so you need to probe further, so that we'll know what we are dealing with, and then of course address it appropriately. Either it falls under urgency, emergency, and of course when in doubt, then you want to know, is there a headache, vomiting and all of that, all those the history of the worst headache of my life and stuff like that, And when in doubt, you're not sure whether it's hypertensive encephalopathy or a stroke, just do a brain CT. Once there's nothing there, yes, there's nothing. Once there's something, you see ischemic or hemorrhagic, then you can address it. Worsening symptom. Oh, is this a continuation of the same question, or is another question? Okay, I think I've answered that already. Somebody was saying differentiating hypertensive encephalopathy from stroke. Apart from the history, which we've already talked about, some with encephalopathy, they might not have the hemiparesis or slurred speech and all that will point directly to stroke. It might just be headache, irrational behavior, elevated blood pressure. But when in doubt, just do your brain CT. Is there a bleed or there's an infarction? If there's none of that, then just know you're dealing with hypertensive encephalopathy. If there's that, we now address it, Then I think that's that. I don't know if there's any other thing. What else again? You're talking of prophylactic antibiotics. Did I get that right? What is it again? I'm trying to read through the questions. I saw prophylactic antibiotics somewhere. I don't know where it is again. I don't know where it is again. I think this thing is rolling so fast. Role of dual antiplatelet. No, for stroke, there's no dual antiplatelet. We're not dealing with myocardial infarction. In myocardial infarction, yes, dual antiplatelet. For stroke, just one. Choose clopidogrel or aspirin. I can't even find that again. I don't know what happened. I'm just scrolling down. I can't see. I saw something. There's nothing like prophylactic antibiotics, basically. So if that's the question, because I can't find it anymore again on the Q&A. But I saw something prophylactic antibiotics. I couldn't read the remaining aspects, but there's nothing like that. Please just examine properly. If there's signs of chest infection, you will pick it up, either from the history or from the chest x-ray or from listening, whether there are crepitations, transmitted breath sounds, things like that. Then you can place an antibiotic. There must be a reason for antibiotics, nothing like prophylactic antibiotics. You must be treating something for antibiotics, for antibiotic use. I think basically that's all. I can see something about seventh cranial nerve pulse. I think it's okay. It's a follow-up from the previous one, because by the time you're now seeing seventh cranial nerve pulse, that's why I said you need to probe further and examine well. when did the seventh cranial nerve palsy come up that we did not pick when you said restlessness? It's glaring, you know. That's why we keep talking about the fast.
Yeah.
By the time you tell the patient to smile, you will know whether there's loss of nasolabial fold, you know. So you can almost tell if there's facial nerve palsy or a mouth deviation.
Yes.
And then when you're talking of seventh cranial nerve palsy, is it lower motor neuron? Is it upper motor neuron, you know, lesion? Because, you know, talk of the wrinkling of the forehead, you know, upper space, upper. If it's upper motor neuron lesion, you know, yes, that can be associated with stroke. But if it's lower motor neuron lesion, then you're thinking of other things. Are you dealing with Bell's palsy? The management is totally different. So that's why I said, for this case, you need to probe further to know what you're dealing with. You know, so when you see the seventh cranial nerve palsy, is there any paresis? You know, do a brain CT and let us know what we're dealing with. That brain CT, because we actually had a case of a, that's what the person presented with, just seventh cranial nerve palsy. And then we did a brain CT, and I came with ataxia. Yes, he had imbalance and all that. You know, we still even saw the patient in clinic on follow-up. We managed the patient, we did a brain CT, and we saw cerebellar infarct, you know, and that could explain why he had the imbalance, you know, and then he had the seventh cranial nerve palsy alongside. So manage as a case of stroke also. But if you're dealing with just only seventh cranial nerve palsy, you need to be sure what you're dealing with. Is it a lower motor neuron, upper motor neuron lesion, to determine what how to manage. And but of course, I said if you're in doubt, please refer. I think we've answered all the questions. Some guidelines recommend avoiding urinary catheterization. Is it recommended and why? What guidelines? Maybe you should be more precise, because I don't know why it's written that you should not catheterize. Rather, because if you don't catheterize this patient, especially when they're unconscious and you feel you want to do your diapers, they'll keep wetting the diapers. You are going to expose them to bed sores. Once you start dealing with bed sores, sepsis, the story changes. They could even deteriorate further. That sepsis could just be what will take that person out, not even to stroke anymore. So we need to be careful about this. If the person can urinate well, and then, okay, it's a male, you're thinking of either post-tube, you don't want to catheterize, you know, but I don't think there's anything that is contraindicating catheterization, especially if the person is unconscious, then you need to do that. For a patient with stroke, how long do you continue IV normal saline? As long as the patient is on the ward, the patient will continue. You could just continue IV normal saline, because by the time the patient is doing well, you discharge. Yeah. So you're not keeping the patient for too long if the patient is doing well. The patient might not fully recover the hemiparesis. You know, it's a continuous thing. But at least once you're sure the patient is off the acute phase and can continue care on an outpatient basis, then you continue you discontinue your IV normal saline, and then you continue care on outpatient basis. But there isn't any particular duration to your normal saline. You continue as long as the patient is with you, especially in the ICU, because it might take a while for the person to now start tolerating orally, because for some, they fail their swallow test initially. Then by the time they start recovering, some days later on, they regain and they can tolerate orally and all of that. But your IV fluid still continues. And then by the time you're discharging, you know, they can, of course, they're already taking orally. Maybe you can now, but we've already said it should be 3 liters, 20 within 24 hours, except there's any contraindications to having the 3 liters, which we need to probe further. We mentioned heart failure and all of that. So we said it's not cast in stone. You have to look at the patient as a whole and decide, but let's know what is expected and know when there's a contraindication to that. I think that's all. We've answered all the questions. I can't see any other one there. So we'll be expecting you. There'll be another webinar coming up the last Friday of November. And then, of course, our ACS coming up in December. It's nice to have everyone online, and hopefully we get to see you again.
We've learned 1 or 2 things.
Yes. And then want to see your referrals when you're faced with difficult cases. Thank you for staying with us throughout this period. Thank you. We still have a lot of participants online. Thank you so much. Thank you. Look forward to seeing you again online and live in ACS. Thank you,
Thank
cardio
you.
care. We just got that. Thank you too.
Muhammad.
Thank you. Thank you. All right then. Bye.